As Jessica said, my name is Victoria Richardson. I am the Clinical Informatics Director now at Bon Secours Hospital. We actually have 14 hospitals up and down the East Coast. We have 7 in Virginia where I'm located at. But what we're going to be talking about, of course, is the adoption versus adaption of the EMR system. But I want to give my panelists an opportunity to introduce themselves. So I'm going to ask John.
Good afternoon. My name is John Showalter. I'm the Chief Medical Information Officer at the University of Mississippi Medical Center. On June 1st, we did a very large EMR implementation. We brought up 23 applications in 5 hospitals and 95 clinics representing 120 specialties. About 1,300 providers, 6,000 nurses. In May, we're all on paper, and on June 1st, they were all electronic. In the last 2 months, we have successfully attested for HIM stage 6, ambulatory and inpatient, and we are waiting for our check from meaningful use stage 1.
Excellent. And Karen?
Good afternoon. My name is Karen Jones, and I'm the Director of Project Management, Clinical Informatics Nurse Lead at the Bon Secours Memorial Richmond Community Hospital and Memorial Regional Medical Center. And I am currently the lead for those 2 facilities. We implemented our EMR back in 2010, and it's been successful so far, but we have also noticed some challenges and some risk issues.
Okay, and because we want this to be a very interactive session, we've all agreed that our first question we actually want to put to the audience, and we want to know, when you're implementing new functionality in your EMR, who is your subject matter experts? Like, who do you get involved? Anyone? Your physicians, yes? Who else? How about your risk managers? Does anyone bring their risk managers to the table, either when they're putting in a new process, when they're doing change control? Because that's something that we've found time and time again has been an opportunity for us. And as we were talking about earlier today, when you're looking at that three-legged stool, where you have process, people, and the technology, part of that people and process need to be your risk managers to be involved in that. John, do you have to say to that?
Oh, I definitely agree. So given the size of our go live, we spent a lot of time balancing risk. I mean, we were not going to be all things to all people, which means something's going to get left behind, something's going to get advanced, and that had to be balanced out from a failure risk perspective, a monetary risk perspective, a legal risk perspective, and our legal advisors and our compliance officers were on our main executive steering committee. They were brought into several of the decisions as needed, and they were an ad hoc members to a number of our governance committees.
And we also involve our risk manager. She will come in before we implement any new functionality. It could be a difficult workflow that we're looking at, and she will perform failure mode effect analysis and help us to go through those workflows to see if we will have any type of challenges where it could fail, where it could be a patient safety issue. And with that information, we're able to go back to our build team and share, this is what we did together, this is where we're seeing some effects that could potentially cause an issue, and how can we work around that before we implement it into our EMR.
And so, and when we're looking at that and we're thinking about adoption versus adaption, what's the definitions that we're basing that off of, just so that we'll have a standardization?
I would say adoption would be the employee accepting the system, and adaption is them adjusting to the system and creating workarounds.
Okay.
And I think that, to some extent there's some spectrum on adoption and adaption, but for me, really, adopting means that they are adopting it the way that we intended them to use it. They're following the policies the way that we wanted to. They're checking the boxes that we need them to check to do the analytics on the back end. If you're just using the record and not using the record as we have designed it to maximize its benefit, I wouldn't give you credit for fully adopting.
And what I've found and what we've had in some instances where we've actually seen them to do it as it was designed, and they said, well, no, the system is working as designed, just to find out that the system needed to be redesigned. Because though it was working as it should have, it was not actually following the workflow that actually provided the care that we wanted to the patient. So then the question becomes, how do you then identify whether your staff have actually adopted or adapted the EMR that you've put in place, looking at workflow and processes?
Yes. So I'd say for the most part, when clinicians adapt something, they don't adapt it in a negative way in their perspective. They're trying to adapt it to get patient care as they define it, whether it's more personal patient care, whether it's a higher volume patient care. I mean, nurses and providers generally do not want to provide bad patient care. You know, there's bad apples in every bunch, but 99.999% of physicians and nurses wake up wanting to give good patient care, and they adapt when they think the EMR is in the way. Probably, the most effective way is to actually shadow them and see how they're using it. That's next to impossible to do on a global scale at a system basis. So we look for surrogate markers in reports. We look for whether or not they've completed their encounters in the time that we think they should. And when we're running quality measures, we're looking for boxes not checked and assuming that if all that stuff's done, you've adopted, even when maybe you've just adapted better than others.
Excellent. And so, part of my job, part of all of our jobs of being in informatics is, of course, to decrease that organizational risk and liability. So in looking at that, what are some of the innovative ways that are actually being employed to decrease that risk, to help our end users to do the right thing the first time?
At our facility, we have implemented the Connect Care Connection, which is, I think everyone should have a copy on the table. During the week, we have daily huddles, and on Tuesday, every huddle is dedicated to our EMR. And during the summer last year, we implemented the EMR Legality and Functionalities Summer Series. And that summer series allowed us to be able to ask the end users questions, physicians, other ancillary departments, different workflows, different things that we had seen, and the staff, they were able to email the answers back to us, and they would get the question on one Tuesday, be able to answer it, email us the answer, whether good, the right answer or the incorrect answer, and then we would give them the answer the following week. That allowed us to see, do we have everything in process in the way that they need to be able to look at the workflow? Do we have the policy there? Do we have the procedures there? Are they updated to incorporate the new EMR workflows? And it was a success. We had our staff that participated. They were awarded movie tickets, and there were sometimes we didn't have any answers, but that also allowed us to see that, okay, this is something we need to look into. We might not have this information for the staff. We also utilize our risk manager to help us do mock trials. We will take information from the electronic medical record that we have seen either a concern with or an issue with. She will make sure that PHI is not identifiable. We will reach out to our legal team. They will help to put together the mock trial. We will bring in nurses, we'll have the bailiff, we'll have the judge, and the staff, they are our jury. And so you sit there, the nurses are called to the stand, you have your attorneys there to question the nurses going through the process, and then at the end, they will do the closing arguments. The audience will have a form to fill out, guilty, not guilty, and Then we'll all come back around and discuss the information. And now we're looking towards doing a deposition. Because a lot of nurses, they don't understand. Sometimes we're in the process of working, going through the day, and with the EMR, you have a lot of check boxes where you check, and you just get in the routine. And sometimes we're finding that through just that checking, when we're going back and doing some chart reviews and you're talking with your nurses, they were like, well, I didn't mean that. I didn't mean that. This is what happened. And so we're just trying to get them to start thinking. My checking and being fast, because I understand the workflow, could potentially set you up for something on the back end. And they really appreciate it.
And John, you was mentioning something earlier about the M&Ms. Would you like to share that?
Yeah, I think one of the ways to mitigate risk is to really push some personal accountability. And we are in the process of kicking off essentially it's a morbidity and mortality conference surrounding duplicate medical records. We're having a fairly decent problem in our institution with people selecting the wrong record, not going through a diligent process to make sure that they aren't duplicating the record. And then there's a big back-end process to clean it up. So we're putting together an M&M conference where if it's a scheduler or a registrar or a nurse, the physicians don't quite really have the capability to do this. Make the duplicate record, they're actually going to have to come and do a presentation on what happened, what they think the root cause was, what they're due to present it again, and do it in a peer-reviewed format, both for us to identify system problems as well as to really push that personal accountability. I think another level or another layer of this is actually governance. Mississippi has a very strong governance structure. We have councils that are multidisciplinary for inpatient and outpatient. We have a physician council, we have a meaningful use council, and we have a revenue cycle council that all go up through two different layers of management. And that really allows us to look at those policies, have people in the room that say, okay, I understand that you have to do this in the record, but if we're going to go down this road, this policy has to be rewritten. This is the approval process. No individual has the ability to make a change to the system. The CMO can't make a change. The CNO can't make a change. I can't make a change. They all go up through the governance councils. And even the highest level, our executive leadership council, doesn't have the authority to make a decision around one of the lower councils. They just have the authority to force that council to make a decision.
Wow. I like that. So going back and wanting to get you involved and wanting to actually to have this to be a dialogue, what are some of the actual or potential inherent opportunities that you've seen with your EMR or your EHR? Nothing, huh? Wow. I need to come and work there. Everybody's had a smooth go live? Okay. And have you found a way to actually do that in a cohesive way that when you're looking at reports across the care continuum, that anyone can indeed take that information and situate it for the patient population that you're looking at? You'll soon find out. Okay. Thank you. Any others? Thank you. Any opportunities or successes? We want lessons learned. We want it to be shared.
I think one of the biggest problems that we had was a lot of the clinical training was not blended in with the workflow. So we taught them how to use the system, which button to click, what to do for that, but we didn't tell them when and how to use it. So they had a lot of problems these first couple of weeks figuring that out for themselves.
So the functionality was taught of how to point and click, but not necessarily the why behind the what of the system itself.
Yeah, and that was definitely one of those inherent balances. We train 5,500 or 6,000 nurses in a 6-week timeframe. We didn't touch their workflows. And we definitely knew, we felt the pain after go live because we didn't touch the workflows. We didn't really touch the physician workflows either. We trained 1,500 of those in 4 weeks. And they didn't get very specialized workflow training either. And, you know, we're 10 months out, we're still feeling some of the pain from those decisions.
Wow. So in not touching their workflows and leaving it as it was, and with the system not mirroring then what the new workflow was?
Oh, I'm sorry, so we changed their workflows, and our EHR, they needed to work differently, but we didn't have the time and training to teach them
To
new
teach them the new workflow, that's what I.
So we had a lot of adaptation because they didn't even know what they were supposed to be doing.
Okay.
They were just kind of thrown at it. And might not be shocking, the nurses are better at this than the physicians, but while you have the physician's attention, you have their attention, and while you don't, you do not. So it's been really hard to refresh them on what their workflows should be.
So then, how do you then go back to actually get that so that when they're caring for that patient in that bedside, it doesn't become a point of click or to some point of having still paper and pen?
We had some paper and pen that were
Okay.
that were then moved into the EHR. We found those when we did our shadowings, so they went on for a little while. But it's been extremely difficult. We have put a lot of effort into having in-person, we're calling them provider bars, where our trainers go out and set up a table and answer questions. We send out multiple emails every week with little tips. We've made a number of electronic videos because they seem to be able to watch those for about 2 minutes, and if you can get a workflow in under 2 minutes, it's pretty good. And then for some of the really core safety programs, we have got them integrated into their standard medical executive committee approved required training.
Okay, excellent. So you mentioned the governance structure earlier, and Karen, I'm going to ask you as well. What structure does the organization have in place to evaluate the risk that comes from new technologies?
At the facility, we utilize our different committees. We also utilize different reports. We will reach out to our CMIOs, and we will have meetings and to discuss what we're seeing, what issues we have identified with our risk manager. And we'll come back together, and we have created different standardization committees, and we will address the different issues and how we can work together to make sure that this issue will not continue at another facility.
And that's, and to that point, one of the things that we've heard, and at least I've heard in several of the roundtables that I've been in, is the standardization. Coming from an organization that we have 7 facilities in a central location, you know, we have floating nurses who could go from one hospital to the next, well, one department to the next, and things be done differently. And so now what we're actually doing is standardizing the workflow, because we have the Epic product, and for those of you who do, there's more than one way to do everything in Epic. So, but what we did was actually teach it all several ways too, but now we're telling people, no, we want you to do it this one way. So we have actually devised end-user work groups, and these are our subject matter experts, and they're the ones that's telling us, no, it works better this way, it gives us more time at the bedside with the patient, and we're shadowing them and we're watching them, and so now we're teaching that one standardized way in order to get something done, and praying that it's going to work.
I mean, we definitely do have our committees and our approval structure up front and our change management pretty well honed. On the back end, right after implementation, we had 100% review of all of our surgical procedures from our coders. Our coders are closely tied to our DIS group. The Director of Health Information Management and I meet several times a week because they're one of our views in. They're reviewing the chart anyway. They know when things look odd, and they've been feeding us back information for us to try to fix. Our compliance group also does a pretty extensive review. They were about a 2 to 3% review of everything got reviewed by our compliance group. That's slowly waning off now, but they've definitely identified some risk areas. One of the main ones is copying and pasting. We're an academic institution. There's risk involved in grabbing a med student note, which is not part of the record, but we can't turn off copy and paste. So they'll copy and paste it, and then they'll have a duplicate note that wasn't the resident signed by a resident. And so we have our groups on the back end that are really feeding back to leadership and to IT where our risks lie.
How does that information that you all get together, how does it get back out to the end user? These are different things that you're noticing, that you're seeing that is a potential issue.
We have several communication channels. We actually have a communication analyst in DIS that is in charge of making sure that we use HealthStream for required education, making sure that HealthStream modules get done and get sent out, handles our newsletter and our physician education communication for me. We maintain a website with announcements as well as with e-learnings. And even with all that, I'm not sure that it gets disseminated superbly well.
That is something. So, and John, I know in earlier conversation, oh, I'm sorry, I didn't see, there was a question? Oh, by all means, please. Jessica.
I was wondering if you'd share an experience in, I mean, you're talking about risk mitigation here, and I just wonder whether there's been any sort of legal case that occurred in your facilities, and you thought, you know, here we go, this is fine, I've got this covered, and this is why, because of these steps that we've taken. I wonder if you could share an actual experience where it was successful in, I don't know, combating a legal
Karen, do you want to take
issue.
that one? For the co-design?
We've had some issues occur at our facility. One concern we had to deal with a patient that was in the ED in our emergency room, and the information, when their discharge information was printing out of the system, we didn't have paper print in between. So there was one patient, like patient A, their information came out, patient B information came out, and they happened to have the same name. And because of that, the nurse just came and pulled the information off of the computer. So the patient ended up receiving the wrong discharge information, prescriptions and everything, went to have them filled. And so what we did with that, once we learned everything, went through the proper procedures, notifying everyone what took place, our compliance officer was very involved. We went back, we did root cause analysis to see what we could do as the facility, what we needed to do with our system to make sure that this didn't happen again. We had everyone involved in the root cause analysis, from the nurses, the ED, from the emergency room, IT, even some of our support applications coordinators. And we sat there and we mapped out what happened. What could we do to make sure this didn't happen again? And so what we were able to do, we worked with our enterprise build team to go in to just, for a simple thing, print a piece of paper, put a blank sheet of paper in between the notes, the discharges, and then we also had to go back and add at the bottom, because not every sheet of paper had the patient name on it. And so we had to go back and add that at the bottom so you were able to identify each sheet of paper went with this person, with this patient, and then there was a blank sheet of paper now that printed off in between the different printing print groups, and we were able to not have that occur again.
So it didn't actually come to a suit, but we had a threat of a suit shortly after go live, because there was a problem on the problem list that one of the patients was not happy was on the problem list. It was a psychiatric patient in addition to a medical patient, and they weren't happy that their psychiatric problem was on the problem list. Now, in our terms, we all know really you're not going to win a suit over that, but you can always file and make us run our legal costs, even if we're fairly confident that we're going to win. But our compliance officer was able to actually sit down with the patient, review why we were doing what we're doing, what the changes were at the medical record, review the policies and decisions that we had made. And then our legal team got involved, and there was talk about psychiatry actually opting out of Epic, and it went back up through our governance structures that said, no, this is what we're committed to, this is what we're doing, this is why we're doing it. And we may end up losing a patient because they're not happy with the way that we are sharing information, but as an institution, we believe it's best for the patients. And that got worked back up through our structure and reaffirmed. And I do think helped prevent the case because we were able to explain why we did it and who all was involved in the decision-making.
Does that help? Okay. Any other questions before we? Okay. No? So, John, what I was going to ask you, because you talked about the human factor, what I call picnic, person in the chair, not in the computer. So if you can tell us some, and I know you've done papers and some research with that, so if you can let us know, how does the human factor or that end user affect the risk assessment that we should be taking?
I mean, the end users are one of your largest risks because of what they would do with the adaption. And you can have a system that looks like it's going to be very safe, but if they choose, and we did have psychiatry, again, they're very concerned about their privacy, decided that they were not going to e-prescribe, and they didn't tell anybody. So suddenly all of these high-risk psychiatric medications are not in the electronic health record. Our providers are believing that almost all of the prescriptions are in the record, and now the patient's coming to the ED, unconscious and doesn't know their medications. You can ask them anyway because they're unconscious. You think you know everything they're on, and you make medical decisions with limited information because a person decided not to use the system as you had designed it to be used. So I do think they put a lot of risk in your system. And then from a medical legal risk, how are you going to defend that if you make a bad choice and that patient has a bad outcome and their attorneys get involved and they come back and go, you said all your physicians were supposed to put their medications in the record and this one chose not to, you're really going to lose that when you try to say that's not negligence. I mean, that's clearly going to be viewed as a breach. So they're definitely your biggest risk factor, and it's very hard to monitor how they've adapted and where they've adapted that's going to make those risks. So I think one of the biggest thing that you can do is actually have that committee that has representation from that area sitting there making decisions and making policies, and making policies that make sense and are clear and are written down. Because if you have a provider that is acting outside of your policy, that provider had a breach, but your institution may still be protected. And that's a big deal to us as a state institution because our providers are state employees. The providers can't be sued, but the institution can. So we are very concerned about protecting the institution, and we've actually managed to win cases where providers have gone outside of our policies or nurses have gone outside of our policies or procedures, and we've said, they didn't do what they're supposed to do. We dealt with them in a HR management for their, misbehavior, but this is not what we do institutionally. We do not have, a breach, and we can't control every action. Sometimes that works, sometimes it doesn't work, but at least it gives us a position. If we didn't have those decisions made and the documentation of the decisions and what those policies were, we would be much further down the road to just writing a check.
Excellent. Thank you.
I just have a question. Did your EMR, did you all have to do anything with metadata, pulling like the data behind the data to see different things? How did, with e-discovery, because that's one of the largest things out there now with e-discovery
Kim, do
and
you want to maybe explain what that is for those
metadata
who may
is
not know?
the data behind the data that sometimes you're able to see when the electronic medical record is printed out. It is not what you see when you're in the chart. And there are times that patients now are asking for the metadata, audit trails and things to be provided when they might be looking at a case or when they've asked the lawyer to reach out to the facilities to get information. So I was just wondering if you all had any of that occurred where you had to pull different information out of your EMR.
We've had some, not a lot. It's more we've had to do some clarifications on what it was and what that data meant, especially when you do the whole record release. We have Epic as well. I mean, when you do the whole record release, the formatting is completely different than it is
Right.
in the record. And You know, it's all there, but sometimes you have to prove it. But that hasn't become a major issue for us yet, but again, we've only been up for 10 months. And we don't have a real sue-happy patient population. We don't get sued a lot, which is good. However, I'm sure this is coming.
So I guess I'll pose that same question out to you all. Have you had requests for e-data from the metadata, when you're actually looking at who has touched a patient's chart? I know there are cases where a patient has asked for the actual screenshot of what the doctor saw that day that order was put in. And as we know, because of such rapid change cycle with the EMR, what we see today could be totally different what they see next week. Have you encountered that? Yes, ma'am. Right.
Implications of the visit summary itself is, because, you know, we have all the diagnoses there, alluded to with the psychiatric diagnoses, but what about the infectious disease diagnoses? You know, that's all going to be there on their problem list and their diagnosis list, and now we're printing this out and handing it out to people by federal stipulation. And yes, we hand it to them in the confidence of the exam room, but of course, they're going to be walking out the door with it and leaving it who knows where for anyone and everyone to see, and that, of course, is that's their own violation of their HIPAA confidentiality. But yeah, I can see this leading to all kinds of issues down the road that we then, as providers, have no control over their breach of privacy. And I can see that they're going to come back to us with a lot of questions.
Yeah, that was actually one of the arguments we made with psychiatry is, you know, schizophrenia or depression is potentially much less embarrassing to someone than the chlamydia
HIV
diagnosis.
or chlamydia or gonorrhea.
Or the syphilis
right.
diagnosis.
Right.
And there definitely are hypothetical situations where somebody comes in and is diagnosed with chlamydia and takes their after-visit summary home, and their wife finds it, and we as providers are going to be dealing with the ramifications of being blamed for the wife finding out that somebody was cheating. You know, there's no HIPAA violation. There probably isn't really a legal
No,
requirement that
it's
they can come
not
back to us,
our
but
issue, but
there's definitely
patients are going to be irresponsible with where they put these things.
yeah,
Right,
there's
and they're
definitely
going to come back to us.
a therapeutic relationship responsibility there, and we're not doing it much at Mississippi either, but there really is very little education about, you know, this is your PHI that you always want us to protect, that we're
Right.
printing out on a paper for you to use at your discretion. You know, please be mindful.
Right.
And those discussions aren't really happening. It's just, oh, here's your printout.
Right.
Yeah, so I think as providers, and because we are mandated to give this information out, I think it's really our responsibility to at least have that discussion with patients about how confidential that piece of paper is that we're handing them, and they're just walking out the door with it and leaving it on their car seat,
Yeah.
or
One of the-
throwing it into a trash can for anybody else to fish out.
Yeah, one of the discussions we actually just had last week before I left was that we're gonna start training our discharge desk staff to fold it
Right,
and hand it to them folded, which seems incredibly basic, but if you leave it,
right.
most of them don't fold it themselves, and we can provide an additional layer of protection simply by folding it.
And really, when you think about it, it's not even the purview of the reception desk people to be seeing those things. And yet that's part of our workflow for them to print it out.
And I know what has been done in some other facilities is that they have actually, again, added it to that long list of consent things that people
To
are
advise
signing
patients.
when they come in, that they, you know, realize that
They
they're
might
going
not
to be
read it.
given
They
this
probably don't read the
sensitive
paper either.
information, which of course nobody is reading. We're just simply getting a signature to, for lack of other things, cover ourselves. So, yeah, definitely something that we need to look at. So,
I have a very quick
Oh,
comment, I think,
certainly.
just regarding your issue about metadata. I think it'll be very important for you to know what metadata you actually are capturing, so that at least you're in a position of knowledge when you give out the medical records to the people who ask for them. I think a lot before EHR, you knew what you were handing out. You could look at
Right.
you could look at the piece of paper essentially, and if it was visible to your eye, you could see it. But I think with EHR and the metadata issue, it's a little bit more complicated, and it just is a good idea to know what it is that you are capturing in the metadata so that you're not surprised when the patient comes back, as a litigant, maybe, and says, well, this, no one told me this, what is this? And you have an obligation that you breached when you gave me this and didn't tell me about it. I mean, those are the kinds of things, I guess, that you would, it's probably good to think about.
Yeah, excellent point. Excellent. I thought I saw another hand up. Okay. So I guess then to wrap up here, one of the things that we've spoken about before that we know, at least from our point, having those policies and procedures in place, and we know, at least from Bon Secours, we have a way to go to actually do that, not only for the adaption of the workflows, but for this new EMR that we've embarked upon. In your governance structure, do they, and I think I heard you say that they actually take on the policy and procedures under that to align, for alignment?
Yeah, so often they don't take on the responsibility for writing the policy or procedure, but they take on the responsibility for not approving the change until the policy or procedure is in
Okay.
place, or to kind of be a watchdog / hound dog to make sure that if something's in place, we have a policy. So one of probably the best example of that is our governance committee came to us and said, you have these drug allergy, drug alerts, and they've got 3 buttons on them. What does it mean when I hit that button? I said, oh, it means this. They said, oh, that sounds reasonable. Does everybody agree on that? I said, no, not necessarily. So I'm now in the process of drafting that. It's not really a policy. It's gonna be a guideline or a standard to just, cover everyone so that they know what happens when you click the clinician reviewed, because there was a lot of concern that they were taking on additional liability when that really was not what the metadata behind that button actually did or created. So they generally don't write the policy. Sometimes they make me write policy, but mostly they just ensure that a policy is done, and often a policy has to be touched or changed before we'll actually be able to make a change in the system.
Before it can go to change control. Okay. Karen, anything you want to add to that?
We're working on getting our policies and procedures in place at the facilities. We're noticing that sometimes there's functionality that's being placed in our system that no one has really sat down to make sure that we have a policy in place, or if there is a policy being worked on, and sometimes it is implemented into the system, and so we have to go behind the scenes and come up with something that is available for the physician, to protect our physicians, to protect the patient, to protect the nurses. We're dealing with something right now where there is an alert that populates in our system that is a very big alert. It says, stop, you scanned blood for another patient. However, it's nothing that is, I'm going to say detrimental. It's just something that is populated in the system that's based on our EMR team, and they're looking into that. But when a patient sees that, or when a nurse sees that, or a physician sees it, it's something big and bold, and it's
Well,
flashing at them.
But explain why that.
And the
is
reason why
actually-
that populates is because it's based on the different components of blood that are, when a unit of blood is donated, you get the plasma and platelets, and so that alert is tied to that. However, when we're scanning our blood, we're scanning in the unit number, but sometimes if the workflow is not followed correctly, this alert will populate. There's nothing in our policy right now telling a nurse to bypass that alert or stating what to do. And so we're having to go back now. We've had to contact our vendor regarding the alert. We've pulled together a team looking at that alert because it is very shocking when it populates, but it wasn't explained that this was a change in the vendor and how they were able to roll out. They changed some wording, but it is a concern because, like we were saying, when you're pulling that data, when that electronic medical record is printed, It's totally different than what's seen in the system. However, now that patients are becoming more aware and lawyers are becoming more aware of the metadata behind it and asking for that information in the audit trail and things, that's potential information that can be pulled now. And so we're trying to be mindful of that to assist in the process in the future.
So you're talking about trying to negate some legality, you know, you're sitting there with your mother, your loved one, and this big warning comes up, and it says you're scanned blood for another patient. Well, I don't want that blood. You know, what are you doing? You know, where are the safeguards that you say are in place because you're scanning my armband, but now this, and it really does, it is really a big in your face. It's nothing you can turn away from the patient, because one of the things that we did with our nurses, of course, tell them don't turn away from the patient. We want you to be interactive with them, so the computer is not a barrier between the two of you, so they see this. You know, they see this alert. So then, you know, what do you do? That's a risk, just a trust risk with your patient, and to try to explain that. And not to have anything in place, not only a script, if you would, for your nursing staff, but for your nurses to have seen that, and we didn't even know about it before it went into the system. So a lot of opportunities, a lot of challenges still for us to come with this EHR.
And there's a good article, and it talks about, there's a case that Victoria had mentioned regarding the wife of a patient who is deceased, and they went in front of the Supreme Court because they had received a copy of the printed record, but she wanted to see the exact screenshot of what the physician was looking at to make the decision. And it's in amednews.com, and it's called The Legal Risk of Going Paperless. And it really talks about some of the different risks,
Okay.
and that's a precedential case.
Any other questions or comments from anyone in the audience?
Thank you.
Well, you had a hand.
Oh, sorry.
So, are your risk managers or risk advisors actually comparing what's in policy and procedures with what's happening operationally, and then driving changes one way or another?
We have one, if you want to, you can
We
answer
have
to the.
one of our risk managers that is very involved, and she is like my best friend at work, because I will reach out to her, she will reach out to me. We will see if there are policies in place. If not, we will come together, we will pull in some of the informatics leads from some of the other facilities to see if they have anything in place, and then she will take it to some of our executive leaders and also ask for different changes to make sure that we do have the policy and procedures in place.
Okay. The challenge with having it as a system where everyone is, we don't have enterprise policies. So there's not enterprise policy. So if something comes up at another facility, and yes, it's disseminated through the clinical informaticist that's there, but not necessarily, that does not always equate then to an enterprise policy throughout the system. Because while we're all the same, everybody wants to believe that we're different. It is. It most certainly is.
We do have enterprise policies. We're a state organization, so we have a little bit more leeway on saying, you know, we're all under one roof. And not that there's less argument, but once we get agreement, it's across the board. As of July 1st, all of our physicians will be employed, so they even fall under our policies now. And that's been extremely helpful, but most of ours are on back end. We don't have any real, other than our governance committees, no one really doing prospective analysis, really looking into it. It's more of, on our back end, someone sees something that they question, and then they go and check it against policy, and then they bring it to, you know, one of the leadership team and say, hey, we saw this happened, and do we need to change the policy, or do we need to educate against this happening? And I wish we had the staff to actually do it more prospectively and do more shadowing and see how things are actually getting used.
Okay. Anything else? Yes, sir.
troubleshooting before, not just specific to your internal folks that you get feedback from, but folks who are on the same platform who are with other institutions?
We do. There's the Epic user group, which is probably the big one that we go to. We do have some of our smaller vendors where some of our people are engaged in what are now our legacy systems, but we're engaged with Meditech and Signature and Envision as well. We're really kind of newbies to figuring out how to find that information in the Epic user group and get it back incorporated. Actually, I got a lot of Bon Secours presentations to learn.
And yes, we actually we have several facilities that we partner with that is also utilize Epic. And I think through that partnership, we've been able to negate some risk. However, again, it's not enterprise-wide, it's not integrated as much as we would like or hope that we could get, but I think that's getting the buy-in of our executives, which we are working very hard on. Any other questions, comments? Okay.
Thank you very
Thank you.
much.